Welcome everyone to another Pearls monthly lecture. Today we have Dr. Nick Szecket, who is a general internist working in Auckland, and he's very kindly offered us his time to teach us about fluid assessment with POCUS. And he was on the Samoa trip in 2025, that's correct. And oh yeah, I also just realized today I've been listening to his podcast for a very long time before even being introduced to Pearls. I am reasoning. Just when I was like looking up stuff for this today, and like so it's really cool. I just realized to actually meet you by Zoom. I didn't realize that I've been listening to you for a while. But
Oh,
yeah,
yeah.
take it away, Nick.
Thank you. Yeah, that's thank you for the plug on my podcast, although we did stop doing it like 6 years ago now. So it's still available if people want to listen to it, but we're not recording any new episodes. Um, well, thank you, and thanks for the invitation to talk about this topic, and welcome to everyone. I'm going to take a pretty practical approach. I will go through a little bit of evidence, but mostly just to take a practical approach, explain some of the physiology and anatomy that's involved at this particular kind of assessment or study that we'll talk about, and then just a little bit of a personal experience. So not too much image recognition on this particular talk. So I've titled my talk, "Is my patient congested?" Because I think that's really the main question that we would have for our own patients on the ward. I'll start with a case here. So this is, this will seem familiar to many of you. I'm presenting a 75-year-old man, ex-smoker, high BMI, past history of hypertension, diabetes, hyperlipidemia, obstructive sleep apnea, and obesity hypoventilation syndrome. We've all had patients that have all of these things put together in one package. And he presents with significant pedal edema and a presumed diagnosis of right heart failure. And so when he actually arrived, his creatinine was 180 on a baseline of 140. And so you start IV furosemide to try and diurese him a bit. But the next day, you find out that the nurses were reluctant to give the next dose of the IV furosemide because his blood pressure dropped to under 100 systolic, and you repeat his creatinine, and it is now 240. And so you're left with this question of, oh, actually, before I ask the question, when you examine him, you confirm that his blood pressure is 88 over 55. He's a bit tachy. He's afebrile. He's saturating 93, which is probably his baseline. He indeed has a high BMI. You can't see his JVP. You hear muffled breath sounds, but no crackles. And of course, he's got the pedal edema. So nothing new there. And this is his X-ray. If you're having trouble seeing it, don't worry about it because there's nothing really to see. It's just a slumpogram, that's poorly penetrated. And you're still left with this question of, have you over-diuresed him, or does he have cardiorenal syndrome? Because clearly what's happened is the kidney function is deteriorating. And then the question is, have you given him too much furosemide? Now he's dehydrated at the same time as being fluid overloaded in his tissues, which we do see happen, or does he have cardiorenal syndrome? And we'll get into a little bit about what cardiorenal syndrome actually is. So what I'm going to talk about is VExUS. But before I actually start describing what VExUS is, maybe I can get someone from whoever's listening to tell me, in this situation, what are some of the things that you could do? So get any volunteers. What could you do in this situation? What do you normally do in this situation? Who wants to
So
give it a shot?
if the patient is not already on inotropes, we can tell him to keep the blood pressure going.
Okay, good. So if you're really concerned about the blood pressure, sure, you could start some inotropes. Now, keep in mind, this is on a ward. This patient is multi-morbid, and the ICU has already been by, and they said there's no way we're taking him to the critical care unit. So you're going to have a tough time convincing your nurses on the ward to start inotropes. What are some other strategies? Who else wants to hazard a guess? I mean, just practically speaking, what would you, there's no right or wrong answer. There's many different approaches, but what are some of the things that you might, how would you make a decision about where to go next with this patient?
I
I
guess
guess, yep, go ahead, Ethan.
I guess you want to make a fluid assessment, uh, which, without POCUS, you could look at the fluid balance chart, do a clinical exam, cap refill, peripheral edema. Um,
Yeah. So you do your absolute best with a clinical fluid assessment, and you come to some decision, which is going to be, I suspect, even given the same examination findings, you're going to have some um, agreement or disagreement about what the actual fluid assessment is at the end of the day. But you're going to use that clinical assessment, and you're going to make a decision. Basically, do I push with the diuretics, or do I need to back off the diuretics? This is a real world decision that you're going to have to make on the ward with the information that you have available to you. And most people, I would say, in my environment, in my department, do nothing other than a clinical assessment to make the next decision. And sometimes the conclusions of that clinical assessment are, I really don't know. I really don't know. I mean, he seems edematous, so I think he's fluid overloaded, but it's possible that I've overdone it with the diuretics, and I just don't know. So what do you do next? Let's say that the conclusion from your clinical assessment is, I just can't figure it out. Because it's hard. He's the kind of patient where it's going to be really difficult to actually get an accurate fluid assessment. So what do you do? What do you actually do at next point? Again, your options are you either push forward with more diuretics, or you back off and give him fluids because his renal function's going off and his blood pressure is too low. Those are your two options. Any takers?
Can we have a look at the IVC and also the left ventricular area and see whether he might need a bit of fluids?
Okay, good. So excellent that you're wanting to use the ultrasound and look at the IVC. And surely I suspect that the IVC is going to give you some information. Um, what I was getting at before is that most people who don't know how to look at the IVC or don't use ultrasound in general with their clinical exam are going to be stuck in this conundrum, and they truly don't know what the fluid status is at the end of their clinical assessment, and they're just going to have to make a decision. And they're going to have to see how it goes, right? So some people under these circumstances would say, I just have a sixth sense that he is overloaded still, and we have to push with the furosemide. And that's what they'll do. And they'll double the dose of the furosemide. They'll continue giving it IV, and they'll see what happens the next day. And if they had some success and the renal function's better, they went in the right direction, and that's how they do it. And if they can convince themselves that they had a pretty good diuresis and the renal function gets worse, then they're starting to get a strong clue that maybe they've overdone it with the diuresis and they've gone in the wrong direction. And so they will backtrack and start adding fluids. And that's literally what people do on the ward, even in my department where ultrasound is available, but no one actually uses it, right? So coming to the IVC, yes. So Rebecca, you suggested the IVC. What do you look for in the IVC?
Whether it's collapsing, and if it's collapsing, is it like a good collapsing more than 50%, or is it too dilated and not collapsing, which means that we won't give any more fluid.
Okay, great. So you definitely get clues for the purposes of answering this question. Is the patient overloaded or is the patient too dry? You're hopefully gonna get some information looking at the IVC. Just to keep in mind that the original studies looking at IVC, they're not fluid status validated, right? I mean, if you remember the original studies, what they actually tell you is only the fluid responsiveness. So if you have a patient who's hypotensive and you want to know whether giving them more fluids is going to improve their blood pressure, you can look at the IVC. And if the IVC is collapsible, you have a pretty good chance that giving fluids is going to increase their blood pressure. And if the IVC is not collapsible, you really don't know. And that's been extrapolated into fluid status. I think it's plausible that looking at the IVC gives us some information about fluid status, but keep in mind that the validation studies done on IVC don't tell us about fluid status. They tell us about responsiveness to fluids in the situation of being hypotensive and whether the blood pressure is going to increase, okay? The other thing that I'll say, and I'll come to this a little bit later, is that the IVC, unfortunately, does not correlate very well with fluid status. And that's the whole reason why VExUS was developed, okay? So we'll move on to VExUS and we'll look at some examples. But what I'm going to try to do over the next few minutes is answer, first of all, describe what VExUS is exactly. I'll give you a little bit of evidence for its use and what it's actually useful for. And then I'll just give you a little bit of personal experience. Okay, so this is just a reminder of when we have congestion from the right heart, right? Because that's what we're talking about. We're talking about right venous congestion, not pulmonary edema, not that side of the heart, but the right side of the heart. And when we have venous congestions, there's several organs that are affected, and we don't really have much of a view of any of these organs. The only thing that we actually look at is the JVP on the physical exam. We look at the ankles, and that tells us, we check for edema. And then now we know how to look for IVC and see if it's dilated and whether it's collapsible or not. But it's actually the organs that mostly get affected. So congestive hepatopathy, where you get enlargement of the liver, enlargement of the capsule, causes a bit of pain, causes liver enzyme derangement. And if you leave it for long enough and it's chronic enough, you can even develop cirrhosis, right? You get bowel edema and ascites. And this is the postulated reason of why oral diuretics sometimes don't get absorbed. So you reach that point of that threshold of no return when you're so edematous that even the oral furosemide that usually works and will work in the future is not working now because you're not even absorbing the furosemide through an edematous gut. And then you also get congestion in the kidney, and this is what causes cardiorenal syndrome. What we call cardiorenal syndrome is when the kidney is so congested that the congestion pressure actually overwhelms the arterial inflow into the kidney. And so you get decreased arterial flow into the kidney, but because of venous pressure congesting the entire organ, right? And all we really have a view of is the peripheral edema. So here's an example of, I didn't actually put the measurements there, but I think, most of us have enough experience doing IVC measurement and observation that we can see this is a dilated IVC. It probably measures more than 2 centimeters, which is the threshold, validated threshold for plethoric. And if you're getting it through a respiratory cycle, you can see it doesn't really move much. It certainly does not have a 50% or more collapsibility. Yeah. So we would call this a fixed plethoric IVC, right? And this is up until now, this is the only clue that we have that the patient's volume status is overloaded. The problem is, and this is again why VExUS was created, was that with chronic conditions, the IVC is chronically dilated. And even when and it just gets fixed in that position, and even when you have varying degrees of fluid overload or fluid status within one patient, the IVC is actually not going to change that much. And so for chronic right ventricular failure, the IVC is not enough to give us the real world in the moment fluid status. So the first question really is, does a dilated and fixed IVC mean that there is congestion? Okay. And the first thing I want to bring your attention to is this is a study that was done in 2016, and it's called 10 situations where inferior vena cava ultrasound may fail to accurately predict fluid responsiveness. And they identified 10 situations where the IVC is going to be problematic to rely on. I've identified the particular ones which I think are relevant to the ward situation. Some of the other ones are more critical care, which maybe you guys are in those environments. On my ward, we frequently have patients who have non-invasive ventilation, so CPAP or BiPAP. Half my patients have asthma or COPD. We're talking about patients with chronic right ventricular failure. And so those patients, the IVC is just not going to give you enough information. Tamponade, obviously, and, intra-abdominal increased pressure. So those are some of the common ones that I've identified that are going to come up quite frequently. Here, what this graph shows you, and this is really important in terms of understanding why a dilated IVC doesn't give you the whole story. If you notice here, once you get to around this area here, the diameter of the IVC really doesn't change very much as you move further along the pressure curve, okay? And so here, the diameter of your IVC is more or less the same as it is way over here, but the pressure is double going over to the right side of the graph, okay? And the degree of congestion, particularly the degree of congestion in your kidneys, which is the whole problem because that's what causes the cardiorenal syndrome, is going to be very significant on the right side of the graph and not nearly as significant in the middle, right? So 15 central venous pressure is not enough to cause cardiorenal syndrome, but 30 millimeters of mercury central venous pressure is, and the diameter of your IVC is more or less the same at these two pressures. So if you just rely on the diameter of the IVC, you're not getting the whole picture, and you might be making assumptions about the degree of congestion. Patient who is sitting here who has chronic right ventricular failure may well be underfilled and need a bit of extra fluid, whereas someone that's way on the right side of this graph is obviously in cardiorenal syndrome. So that's sort of the threshold, and that's the threshold that they've validated. And this is where we get the 2 or 20 millimeters of the diameter of the IVC as the starting point for this study called VExUS. Okay, so I'll quickly describe VExUS and what it is now. There are 4 tasks that we need to do with VExUS, okay? The first one we've already talked about, it's the IVC. You measure the IVC at its, the most dilated state. So you guys all do that. You freeze the image, you scroll back to see where it's most dilated. And in a fixed and dilated IVC, it's not going to make a difference. It's going to look the same all the way through the cycle. And you measure it. If it is greater than 20 millimeters, then you continue with the VExUS examination. If it is less than 20 millimeters, then there's good information that the central venous pressure is below 15, and you really don't have to worry about cardiorenal syndrome and significant venous congestion. So that's the starting point. If your IVC is less than 2 centimeters or 20 millimeters, you can abandon the rest of the VExUS exam. The problem is not venous congestion. Okay. However, we're not talking about those situations. We're talking about the opposite. So if the IVC is greater than 20 millimeters, that's when we move on to do the 3 other tasks. The 3 other tasks are pulse wave Doppler. We are acquiring pulse wave Doppler images of 3 structures: the hepatic vein, the portal vein, and the renal vein. That is the examination. And here's pictorial examples of that. So you've got on the left side the hepatic veins. That's a picture of very dilated hepatic vein tree. But you put your Doppler gate somewhere, ideally the most vertical vessel to the probe, and you get a pulse wave Doppler reading from that. Then you move on to the portal vein. You guys remember the portal vein is thick-walled, bright, thick walls, and you get a pulse wave image from that. And then you move on the right side of the screen. You've got the you can see the color on the kidney, and you've got both arterioles and veins at the peripheries of the pelvis of the kidney. And you want to put your gate anywhere there. It doesn't really matter whether you hit an artery or vein, because actually they run together. And so when you look at the renal pulse wave Doppler, you're going to both get an arterial wave and a venous wave, and you're focusing on the venous wave. And I'll show you examples of that. Just to review the anatomy real quick so that we understand what these waveforms look like and why they look that way. Remember, traveling back from the heart, right? And this is not the direction of flow of the blood, obviously, but traveling back from the heart in reverse, what we have is the right atrium that drains into it's the other way around because it's going in the opposite direction, but that leads into the inferior vena cava, right? The inferior vena cava is directly connected to the hepatic vein. And so you can imagine that the pressures in the right side of the heart translate directly into the hepatic vein, okay? But then the hepatic vein bifurcates into the sinusoidal system, and on the other side of that sinusoidal system, you've got the portal system, right? And so by the time you get to the portal vein, all of the pressures and the pressure changes from the right heart no longer translate into the portal system. They've been completely dissipated by the capillary system inside the liver, okay? So you can imagine that if you do a pulse wave Doppler sample of the hepatic vein, you're getting direct transmission of all the right heart pressures into the hepatic vein. So you should see lots of waves there. By the time you get to the portal system, you should see a flat venous hum. Okay, this is just a continuous venous hum. Of course, it's going in the other direction. The portal vein has drained from the intestinal veins. It's now going into the liver in a steady stream. The liver does its filtration, and then that coalesces back into the hepatic vein and back into the right heart. Okay, so that's just a review of the anatomy just to explain why you would get the different pressure tracings under normal circumstances. Okay, so this was the original derivation study for the VExUS study, the VExUS kind of scan that you do. It included 145. They were all post-cardiac surgery patients. So they actually knew that they were dealing with, they had the measurements of venous congestion directly because they had these patients all lined up with all the catheters. But the outcome that they were actually trying to predict using VExUS was the subsequent development of acute kidney injury. So they're looking at these patients, 145 of them. They know what their pressures are. They're saying, let's develop an ultrasound study looking at these different factors and see if we can predict whether these patients will develop acute kidney injury from their venous congestion, right? And depending on how congested they were better able to predict this, okay? Here's a schematic looking at, pretty much what the waveforms actually look like, okay? So you can see here the hepatic vein. This is what normal should look like, what your waveform should look like. Then your systolic wave starts getting smaller and smaller, and finally you get this sinusoid sort of appearance. Okay, so keep that in mind. The thing is, I've been doing VExUS, I was telling Ethan, for 3 years, and I didn't really know what any of these waves looked like until maybe last month. Okay, so don't worry about memorizing what the waves look like at different stages of congestion, because you probably, what you'll do is you'll carry around with you on your phone a picture of this schematic so that you can then compare with your pulse wave Doppler. Okay, here's the portal vein. As I mentioned before, you get a venous hum. The only change here, you're not seeing pulsatility, you're seeing respiratory variation. Okay, and as you get more and more congested, you start getting some pulsatility in the portal vein. This is retrograde right heart transmission of pressures as it becomes more and more congested and high pressure. So you're actually getting transmission of the right heart pressures through the sinusoidal system into the portal system. Okay, so you can imagine that once you're completely pulsatile here in your portal, you get a lot of pressure transmitting back through the congestion, and even to the point that you're starting to get flow reversal, right? When the congestion is so severe. And then finally, you look at the kidney. You're not worried about the arterial tracing so much. You're worried about the venous tracing, low resistance tracing, so a continuous venous hum through the venous system in the kidney, and then you start getting some changes, and in particular, when you start separating out systole and diastole in the venous system, that's when you know that you're very congested, okay? This is probably the picture that's going to be more useful. It's depicting the same things, but it is what you're actually going to see on your tracing. So this is more like the waves that you're actually going to get. Okay. So again, I'm not going to dwell too much on because you don't want to memorize these. You're just going to carry this index card around with you if you ever decide to do a VExUS study. Okay. This shows the comparison between a severe VExUS score, so a grade 3 VExUS score, and its predictive abilities compared to, on the right side of the screen here, the central venous pressure of greater than 12. Okay, so remember before we were looking at the diameter of the IVC and how that correlates to central venous pressure. If you take a central venous pressure of 12 and you ask that threshold to predict what your what the chances are that you're congested, that's the prediction capacity of a central venous pressure of greater than 12. And that's your prediction on the left of the screen is your prediction capacity of a grade 3 VExUS score. So a lot better predictive capacity. You're going from the same pretest probability to a much stronger post-test probability of there being congestion. Okay, remember they talk about area under the curve, and so this gives you a much higher area under the curve than this curve here. Okay, so then the question is, well, does this actually work? So this is a meta-analysis and a systematic review, and it was aiming to answer the question of whether a high VExUS score actually predicts the development of acute kidney injury, because we only have that initial derivation study. We have, and then there's been a bunch of validation studies along the way. They've all been small. This is a big meta-analysis and systematic review looking at those results. And I just want you to focus here at the bottom. If you look at the and these were a combination of cardiac surgery and non-cardiac surgery. If you look at the bottom here, you see that it does, if you have a VExUS score of 2 or 3, it is actually predictive of congestion more, compared to a VExUS score of 0, okay? So if you can get a VExUS score on your patients, it does give you useful information. That's the bottom line. I guess the next question is doing a VExUS score, is it actually measuring volume status, okay? And in this study here, I won't give you the details, but the bottom line is that the relationship between the VExUS score and the volume status was not linear, but it does give you a pretty good indication of volume status. What they did here, just to describe it a little bit, is they actually used hemodialysis patients. And so they did the VExUS score before doing hemodialysis, and then they did the VExUS score again after doing hemodialysis, where they knew that they had drawn off 2 or 3 or 4 liters of fluid. And so they knew for sure that there was a lower fluid volume in each of those patients after dialysis, and they repeated the VExUS score blindly, and they found that there was a difference. And so doing the VExUS score actually does tell you about the volume status, although it's not a linear relationship, okay? And this is correlation of VExUS score with right atrial pressures, and again, there is a correlation there. So it does actually give you information about volume status. I won't dwell on that for too long. The next question really is it useful for the practical management of my patient? Okay, so this was a comprehensive review, venous excess ultrasound and evidence. So basically this publication was very recent. It was January of this year. And unfortunately, it concludes that we don't have much evidence to support the use of VExUS to guide diuretic therapy, which is really the big question that we're trying to answer. So a bit of mixed results. Physiologically and plausibility, we have good results saying, yes, VExUS actually gives us some good information. Yes, it tells us about the volume status. Yes, it tells us about atrial pressures, et cetera, et cetera. But when they actually look at whether it is useful for guiding diuretic therapy, which is what we actually have to make a decision about, it's mixed results, not that useful. This study I found interesting because it looks at IVC, hepatic vein, and portal vein, and it excludes the kidneys and the renal vein, which I was very excited about because I've never once gotten a good tracing of the renal vein, unfortunately, in my 3 years of trying VExUS. And so I've been very frustrated trying to use it and, have barely been able to get hepatic vein and portal vein when I want to. And so this study looked at excluding the renal vein and seeing if you can still get good information from this. It was a very small study, so you have to take the results with a grain of salt. But their conclusion at the end of the day was that, yes, you might get enough information about their volume status without the renal vein. So this is very encouraging for me, a great relief, because as I said, I find it very difficult to get renal vein. Maybe it's my machine. Maybe I should blame it on the machine. So they suggested this algorithm, which you can see here. Basically, you rule out post-renal as the cause for your AKI. You then do a VExUS. If your VExUS score is 0, then you consider giving IV fluids and seeing if the renal function improves. But if your VExUS score is between 2 or 3, then they suggest doing a cardiac echo. If there's dysfunction, you give diuretics and consider some inotrope. Someone mentioned that earlier in the talk. And if there's no cardiac dysfunction, then you just give diuretics and you go from there. So coming back to our original patient, I'll just remind you, this is a 75-year-old for those who missed the beginning. 75-year-old man, ex-smoker, high BMI, past history of hypertension, diabetes, hyperlipidemia, obstructive sleep apnea, obesity, hypoventilation syndrome. He presents with pedal edema, presumed right heart failure. You start diuretics, but you have trouble giving him diuretics even the next day because his blood pressure is dropped to 88 over 55. And you repeat his renal function, and his baseline is 140. He came in at 180, and now the next day it's 240. And you're asking the question, is my patient congested and has cardiorenal syndrome, or have I overdone it with a diuresis? Okay, so here's this obviously was not the patient because my patient is a cartoon, but this is just to show you that the subxiphoid view, I don't see anything major in the ventricles. They seem to be beating okay. There's definitely biatrial enlargement on appearances here, although I'd want to look at that with a different view. Here is the IVC, which has been measured. The diameter is more than 20 millimeters. So this means, okay, if we're going to do VExUS, then we move ahead with the VExUS study. Here is what I got for the hepatic vein. Okay, so if we compare that to that schematic that we originally talked about, let me just, does anyone want to hazard a guess? Which image would you compare most to what I got? What did you say? It's normal, a mild abnormality, or a severe abnormality? What do you think? Who wants to hazard a guess?
Mild abnormality.
Yeah, it looks like a mild abnormality. And, it's very frustrating that this is the only index image that I have. And my tracings, first of all, never look this clean. So that's the reason I included this one in this talk. But even when it does, it never quite looks exactly like the index image. So that's the hepatic vein. And then this was my attempt at a portal tracing. Who thinks that it looks like anything? Any takers? It's not a very good tracing, is it? I mean, I guess the only thing, because I was probably off the mark a little bit, and that's why it wasn't having a great pickup. I'll just throw in another thing is that, another limitation is that it really helps if patients are able to hold their breath. And most of the patients that you want to do this on are not able to hold their breath. So it's just another challenge. What I would say, though, is if I was on the portal vein, I am seeing pulsatility. Any way you look at it, I'm seeing pulsatility. So I can't really say whether it's severe. I probably wouldn't go that far, but at least I'm seeing some pulsatility. So there's some evidence of congestion. So I think putting those two things together, not surprisingly, I would say I'm favoring congestion and cardiorenal syndrome for this patient. Any comments on that? Any questions about that? Okay. This was another patient that I had recently. And he's, as you see him, he's a very, very frail elderly man. He didn't actually have a history of heart failure that we knew about, but when he came in, he examined as severely congested. And he was being diuresed. I inherited him on the ward. He was being diuresed with 20 milligrams per hour of furosemide infusion, and he wasn't putting out too much fluid. And his kidney function was going off. And so again, the question is he congested or has he been over diuresed? Are we somehow going in the wrong direction? His kidney function was very poor, especially for his age and his size. So once again, we do the IVC, we measure 2.8 8 centimeters in this particular instance. So that gives us the clue that we should move on and we can complete the rest of the VExUS exam. He was very challenging to do. I would argue that here in the middle is the part of the pulse wave Doppler that I would pay attention to, because I think I was off the mark for most of this. And then the sound of the Doppler actually got louder right here, which gave me the clue that it was finally on the hepatic vein. So I'll just go back to that picture there. What would people compare it to here? So have a look at those images. And I'll go back to his tracing. Any takers?
Severe.
Yeah, it looks severe. I mean, I would argue that what we're seeing is the beginning of that sinusoidal pattern running through here. And so he was severely congested, which was, I guess, not a huge surprise because we knew that he was overloaded, but he wasn't, he was a very thin, frail man. He wasn't that edematous. And so I guess that was somewhat helpful. I mean, we knew what we were doing with this man. He was actually dying, and we decided that, and with the family, that he was going to be for palliation, given that we couldn't seem to reverse any of what was going on. So it didn't actually change any of the management in his case. And I have to admit, in his case, I could not get the portal vein even, and so I didn't even record an image of me trying. I probably should have recorded an image of me unsuccessfully trying a portal vein. So I will finish there with the presentation, and I'll just leave you with these take-home points. So first of all, VExUS is a validated index. I didn't actually give you the numbers of how to add up the points, but less important. It's just about those tasks, and then there's an actual index number that that gives you a grading of how congested they are. But you can look that up. But it is a validated index for predicting acute kidney injury from congestion. That's what it was originally derived for. There's evidence that VExUS does in fact reflect volume status. So it does give us true clinical information if we can get it. It's more accurate than an IVC measurement for predicting venous congestion. So it does give us more information than just doing the IVC. I would say it's technically difficult. Maybe I'm particularly not talented at ultrasound, but I don't think that's true. And I've been doing it for 3 years. And even if I was untalented, I would have picked it up by now. And I still find it very, very challenging. And so my conclusion is that it may not be the most practical strategy for everyday use on the ward. Maybe it would be more useful on a renal ward. Maybe it would be more useful in critical care where you have more time to do ultrasound at the bedside, and maybe you have more control over the patient's respirations and you can get better images. But for general ward practice and maybe in the emergency department, I think it's probably not worth the squeeze. And I say that because, as we talked about at the beginning of the presentation, when you're presented with patients like this, usually we just take a best stab using clinical information, maybe some IVC if we like ultrasound, and we take a guess. We go in one direction, see if it works, and if it doesn't work, we backtrack, we go in the other direction, and that might be just as useful. So I'm not discouraging anyone from practicing and trying this. I still find it useful, but it's a lot of effort for maybe not as much benefit. So thank you very much for listening, and I'm happy to take questions. I noticed that there's some questions on the chat here. Okay, it's just in answer to some of my questions from earlier on.